rights to who's doing what. Tell me what the easy answer is.
They're requesting for the patient.
Okay, I'll buy that. So there is no easy answer. There is no black and white clean answer, right? So the idea in terms of waiting through DNRs and the like is messy at best and horrible at worst. We talked about ethics. Remember we talked about ethics a while ago. In the course of caring for elderly patients, ethical concerns will come up. Ethical concerns in terms of who's responsible for it. Ethical concerns in terms of patient advocates. So multiple decision makers, questions about patient's competency, and finally advanced directives or DNRs. Depends on patient wishes, and you kind of talked about that already. That in the end, the patient, as long as they're competent, have the ability to make decisions for themselves. The problem is that, as we've already been talking about, where do you draw the line as far as competency? And so that's kind of the black and white, if you will, as to where they no longer can make their own decisions along the way. What's palliative care, by the way? Only supportive, right? So the idea in terms of comfort care, if you will, is considered palliative care. And palliative, by the way, is part of DNRs for making that decision. Medicare hospice. We are going to have Hospice of Spokane in here next week or the week after. That's going to be talking about interaction with EMS. Always a good discussion that's coming your way. But in the meantime, the idea for hospice interacting with you typically in the last 6 months of their life. It can be extended out past that, but the typical type hospice extension is about 6 months or so. If the order is valid, CPR is not indicated for cardiac arrest, depending how it's worded, depending on what it says on the DNR. May question patient's competency to give informed consent or refusal of treatment. That's kind of what we were talking about a second ago. The idea that the patient has the ability to make that decision. The idea that the spouse has an ability to make the decision would be the other thing that's part of this. We've talked in the past, but remember that living wills and DNRs do not play so well in the sandbox together out in the pre-hospital setting. Although there's a whole lot of confusion, especially these days, to where patients are admitted in hospital. What's one of the first questions they ask? Do you have an advanced directive somewhere along the way? And the assumption is what gets pushed in the hospital is a so-called living will. So the idea in terms of there's a whole lot of confusion about advanced directives versus DNR. And so the confusion continues, and it's not an easy solution. Allowing people to give directions about end-of-life care to its need. And so the thing about it is sometimes palliative care is the very best that we can do as far as arriving on scene and taking care of not only family members but patient as well as family. Durable power of attorney appoints a decision maker when patient is unable to make own health care decision. Here's the kicker. Have you seen a durable power of attorney where there's more than one person? Yes. That gets kind of hairy, don't you think? As long as they're in agreement about that, then that's okay. But when you have to pick one versus the other, then all bets are off in terms of how it's going to go. Same thing with a living will. Living will is expressing your desire, but it does not stand up on the pre-hospital side. Living will is more of an in-hospital type thing. Questions about that at all? Just to read out. Go ahead.
What if you do have two decision makers there on that paperwork and they completely disagree, and there's no ground called medical control, or what do you do?
That hip pocket, and I'll tell you, I've told you this before. I don't, in all my years, I can probably count the number of times on one or two hands that I've used medical control to get me out of the jam, but that's one to get me out of the jam. And I want deeper pockets than just me in terms of making that decision. And so I'm not reluctant to use it for that.
What about the patient that has no one and they can't make a decision?
I'm sorry, say it again.
The patient that has no one, they don't have
Oh, yeah.
dependents or anyone.
Yeah,
they can't
so
make
again, I think what Charlie said earlier on, doing the best thing in the interest of the patient. The idea that you go in with the idea of serving your patient well, and making decisions based on that, I think probably is your best bet. And I think that's an ethical stronghold for it, if you will. Make sense? We just got finished solving the world's problems based on a little discussion, right? No, not so much, but the idea that it goes on and on. It's just a reminder that it's one more quagmire that you're walking into with this thing. Yeah.
Has there been discussion on, or any case studies that you've heard of, or judicial cases, I guess is what I'm looking for, of EMS being involved with the power of attorney? I mean, those power of attorney documents, I mean, that's why we moved to the green form for
Yeah.
DMRs, because there were so many that did look different.
Yeah.
I mean, some of them look like the last page of a legal document with a signature,
Right.
says power of attorney on it. You
Right.
could just type out on Word really quick.
Right.
That, have any of those ever been invalid and they followed the,
Not that I know of.
alright.
Yeah.
'Cause those all seem pretty unofficial.
They are.
When you see them.
And I'll tell you this as well, that you may not like the DNRs in Washington State, and even in Idaho, they're kind of similar, but a wee bit different. You may not like them a whole lot, but I've seen other places to where a DNR is written on a prescription pad, and it's valid. And so the idea, while what we're used to looking at here in Washington and Idaho are those two different forms, there's plenty of other places that come with even less than what you see here. And so, I think we're probably pretty fortunate. We may not think about it that way, but I think we're probably pretty fortunate based on at least having something about it. Any other questions? All right. Doug, we'll be back in just a second. This is your next hit. We've got this, and we've got one more after he's done, and then he's going to be out of here for the afternoon. Fair enough?
So we're going to talk about trauma, musculoskeletal disorders, and falls in the elderly patients. Again, a lot of these things that we're going to talk about can go to any age. It's not specific to the elderly, right? We're going to see people who fall at a lot of different ages and have these things. And again, if you're having regular exercise, you've got a good diet, you're able to care yourself, you're able to heal yourself, you're going to respond better from these than those people who have not the ability to because of poor nutrition, because of they're already not ambulating around or activity around. They have more chances of having injuries in that. Other aspects that we're going to get into with this is basically the predispositions for falling, right? So as we get older, it's going to be a lot easier to fall. As our eyesight goes, what's easier to do? Well, it's easier to trip. If we're having been having atrial fib and high blood pressure uncontrolled our whole life because we aren't taking medications, aren't able to take medications, we're more likely for strokes, for heart attacks, other things that can cause the falls. If we're not hydrating ourselves well because we're drinking coffee all day and we're not drinking fluids at all, we're dehydrated, we're more likely to stand up and have a syncopal episode and fall. All these types of things just put us into more of that ability, and as we run in a dehydrated state anyway. That isolation, and the big thing we see up in the Northwest is that depression. Depression because of one, this lack of sunshine. We see that huge in the areas, and we see a lot of people that comes in and they have, like especially over in the Seattle area, I hated when I lived over there, and they basically dispense lights to people, basically sun lamps to be in front of that to try and build some of that vitamin D and keep people from less depressive states. That's why Starbucks is so huge there. But again, that's there. But what about the isolation and lack of basically everyone else going? It's funny, when I talk to my parents, it seems like every other week, well, we're going to this funeral this week. Oh, we're going to this funeral this week. They're kind of seeing friends and family are going, and there's less and less people for them to hang out with that they normally do with. So those depression things happen. Now imagine you've had this, you've watched your friends, you've watched your other family and that start to die off. You've got your kids who now probably live in another area, or they're busy with their lives doing things that you're not able to get up to. And your spouse, who you've been with the entire time, now dies. Think of that emotional support that happens to these people. So a lot of things come into factors for them, and them not even really taking care of themselves at a point in time. So what are some risks of falls people have? What are the trip hazards, the different aspects that they're going to have that you're going to see these elderly people fall? We've all gone and falls, right? What's causing them?
Rugs.
Rugs? Yep. Pets?
Pets.
Absolutely.
Vagalin in the bathroom.
Lots of different aspects, right? So what's our job when we're going on a fall too? Absolutely. And why do we want to know why it happened? Exactly. How can we prevent this going on? So if you go into a house and you see those rugs that are sitting in there and the throw rugs on the floor and it's a linoleum floor that's easy to go, talk about, hey, maybe we can come back and put some tape on there. I don't know about you, our fire departments have a union that'll come back to places and do this besides care teams, but start looking and trying to go, what can I do to prevent this from having injury? Because what happens when that person falls and breaks their hip next time? You just put them into a sentence into the hospital. What's that?
50% of them die within the year.
Absolutely. So a lot of those different things. So it's kind of watching those, and then it's also finding out why did they fall, looking for the abuse side of things too. So what's important here? When you look at this.
Physical exam.
Okay? Obviously physical exam. Good job. Pay attention. Getting those baseline set of vitals too, of seeing where they're at. And baseline set of vitals is their baseline operating, what is normal, which sometimes we're getting from other people. Getting into that sample history of what's going on, and it's really delving in to find out, is it an older new pain? And then the physical exam of getting those touch on. But find a baseline, see where they're sitting. Is this person operating baseline or are they not? I was talking to Carolyn about my daughter when she'd fallen up at 49, and they called me and they go, yeah, it looks like she hit her head, she was wearing her helmet, but I think she's okay. I put her on the phone with her and I hear her voice and it's like, nope, that's not my daughter. She's talking in the singy song kind of voice and could have sounded normal then, but they don't know. So it's determining those baselines to say, yep, there's an issue or no, there's not an issue. So you got to early determine on what's baseline for that patient. Where are they operating at? Is this normal for them or not? So then you can go from there. Anytime we're dealing with these injuries, again, when you're doing loss of function, you're basically, some of these injuries are death sentence in some of these patients' mind. I don't know about you guys, but I used to have to go to the old school nursing homes where you walked in and it reeks of urine, and they were the most disgusting places, and it was poorly taken care of. If anyone's ever been up to Wellesley and Market, if you're familiar with the area, and then when you turn, like, is it Market coming down? Is it Market going up or Market coming down? Market going up, what's coming down?
Haven.
Haven? Okay. So right at the corner of Haven and Wellesley then.
Where all the bones hang out.
And it's that building without the boarded up windows. That was a nursing home. And we used to go in there. And it was the most disgusting place. And I felt bad for anyone who was in there. You'd walk in there and they'd have basically a bed on a steel frame with a rubber sheet over it, and the patients would be laying sometimes in underwear, sometimes in a diaper, no clothes, no blankets sometimes. I mean, they were disgusting. Fortunately, we're not finding things like that. We're finding nicer places. But a lot of people, that's what they remember. They remember seeing their parents or other places and things in these kind of conditions, and they think, shit, if I'm doing this, I'm going to have to go to a nursing home. I'm not going to that. That's what they envision. So sometimes you have to kind of relate to what they're thinking, because what we see in nursing homes and what they remember may be two different things. And they can't tolerate it as well. Osteoarthritis is huge. The weekend warrior syndrome that basically all catches up to you. There's so many patients I know who are basically holding off total knees or don't get the total knee yet because they're not ready for the surgery or that aspect. And they're in pain walking around, and they just have a hard time moving in general, so they don't want to move. And when they don't want to move, they're not lifting things, their bones become weaker. When their bones become weaker, they lose muscle mass. That makes it harder. Then when they do stand, they're weaker and they can't stabilize themselves and they're more prone to fall. So all these things basically just compound and compound and compound on each other. Makes things more difficult. The joint pain with this here, if they do have to get into a leg brace or something like that, they're not able to move around as much, so that makes them more susceptible. They can get deformities. Basically the crepitus or grading, that's that bone on bone, is that osteoarthritis coming in. They can have rheumatoid arthritis. What gets worse is when they get more of this falls in that. Some people are really just higher susceptible to osteopenia and osteoporosis, and their bone breaks down. Now when they fall, they actually are much easier to break. I talked about a gentleman who was outside shoveling his driveway, and he twisted on the ice, and his leg planted, and his upper body just rotated, and he spiral fractured his femur right up. Femur should not break like that easy. But you get to the point where you're not using things, the bones break down, body uses calcium out of it, they get osteoporotic, osteopenic, and they get these fractures a lot easier. Simple falls that you and I would take right now and have no issue with, they can't sustain as well, and they do fracture. Ankylosing spondylosis. This is something, unless they tell you have it, it's hard to see. But this is their back, and you'll see these patients in chronic back pain. Basically what's happened is, imagine osteoarthritis of a joint. Now consider each spinal area between the body of the vertebral body and the disc as a joint, and bones are starting to wake and break through there, and that's starting to fuse around it. They call this a bamboo spine because if you see x-rays of this, you'll see parts of bone fragments come up and almost looks like a bamboo with the segment coming up. And any motion in that back, that bone starts to get cracking and it just hurts and they're in pain. Now try and take this person who fell and put them on a backboard. They're not going to tolerate it at all. So they've got a lot of challenges with this. It's their inability to flex. Most of these people, what they have to do to fix these areas is they're going in for fusions. Well, now you take someone who's had an injury, who's not eating well, who's dehydrated, whose muscle mass is going off. How well are they going to heal? Not very well. We would put on feeding tubes sometimes because they're not eating and everything else. So it just adds so many other components to this. This you can obviously tell is old because what's the leading cause of death now for the elderly population? Sepsis is actually sepsis just overtook falls, surprisingly. And that was just recent, this year, I think, in a study they went through and found that. But falls, they're not going to be able to recover well. Sepsis, they don't recover well, and that's why, too, we've had our policies for our sepsis alerts and everything else because of the seriousness to it. Motor vehicle accidents. They don't survive well in them at all. Big collisions on there, they don't have that ability to take those shock waves, to take some of those forces on there. And then we'll get into burns more specifically as we going through. But again, it goes, everything kind of relates on how they do and how they're going to be able to survive those. Not so often are we going to see the penetrating trauma with them, but we are going to have to be looking out for elder abuse as we look for child abuse. And again, this kind of even goes back into the, I talked about before we're talking about communication, is taking care of that caregiver who's got that burned out syndrome. Sometimes they can act up and they can react, and so you also have to be looking out for that elderly patient to see how they're doing. So let's talk about aging with this too. So how well is that compliancy going in for being able to breathe? Well, you got to think about this. If their muscles aren't working as well and their body moving around, how are those accessory muscles going to be doing? Their chest muscles, they're not going to be moving well, so it's going to be harder for them to get full chest volume in that going out there. Think about the cardiac, the heart system. What's that going to do? That's a muscle too, right? It can weaken, it can get tired, it can have more changes on there. So you got to be thinking about all those type of injuries. So how do we take a patient who's basically now all of a sudden breathing harder, they're getting that heart to beat faster, but how are we getting that cardiac output? What is cardiac output? Stroke volume and heart rate. So you take what's the stroke volume on a muscle that's getting harder and harder to work? Probably not as good, so that's going down. And so you're not going to get that cardiac output the same, so they're not putting out the same. So you're going to see sometimes lower blood pressure. Now when you got someone who's got a higher blood pressure, it's beating harder, that heart is working hard, how likely is it to give out and to get CHF? Very likely for these patients. They're having to beat to basically try and increase that output or pushing against things. So all these factors are going to come into play, and you got to be thinking about that. When we talk about our physical assessment, again, this is not specific to geriatrics. This is to everyone. But again, it's assessing both sides. But I'll talk about this aspect. So when you're looking at someone, you guys ever seen someone with cataracts, and it starts clogging, it can affect your appearance and how they're reacting. You get one side different from the other side. They can have previous conditions with strokes, and you're trying to figure out between previous strokes and what their symptoms, whether this is newer onset, whether they've had surgeries going through. I actually had a patient where I started listening to the lungs. Well, actually, I didn't listen at first. My EMT listened first and said, yeah, I got nothing on the right side. Right lower side, I got no lung sounds. So I went back and listened to it, and sure enough, and of course, I'm listening on top of the shirt. It's a thin shirt, listen to, yeah, I got nothing down here. He goes, you ever had something? Oh, yeah, my right lung removed. Okay, well, that makes sense, obviously, right? But at first, you're like, okay, is this a serious condition or not? But it's asking this patient. Sometimes surgeries are going to affect different things when you're looking side-to-side comparisons. So it's asking those questions. Sometimes we don't ask, and we just have to figure those out, and those can make complications or challenges. These aren't any risks for falls, are they? So these are all the things that we see. So basically what our things are is to find out is what caused the fall. Which one of these was the factor that did it? Yeah, it could have been all of them, could be the components, but it's also going to affect our treatment. I mean, what's our seriousness of a mechanical fall versus I don't remember falling? Huge difference, right? In my mind. It could be there because now am I dealing with a central nervous system aspect where this could have been a stroke, TIA, simple vagal response, whatever it is, but I got to determine that down versus, oh yeah, I was walking, I remember slipping and falling, I never hit my head. That's got a different level to me than I don't remember falling. Different acuity levels, and we got to be able to pick that out. And then what was the factor of doing it? What basically caused that fall going in? So I need to see which system do I need to come through. And even once I've determined what the fall was, whether I feel like, oh, it was a mechanical fall, okay, I'm not as worried about it, but now I've got to really assess what's going on with that patient. Because they may have neuropathies too, and they're not really feeling that they've got a broken leg. They don't understand it. They're like, well, I feel fine, I just can't get up, right? I'm sure we've been on all those. I've been on those. I just can't get up. Can't get my legs up. Okay, well, that's because your hip's broken. Once you do the assessment on them and get your hands on them, you find that out. But they don't even realize that. Better know splat, right? No, I'm just kidding you. Charlie better know splat because I had...
Yeah, but you said you don't need to know it, it's always on the test.
That's right, so put it on there. Splat's another mnemonic there. It's not a very nice mnemonic for reasons, but basically it's determining on what you need to know when someone falls. So when someone falls, we want to know, okay, what's going on? Is a fall, is just the fact that someone fall an issue?